First of all, I'd like to welcome you guys. I'm representing the MEC operations chiefs. We decided a couple of years ago we were going to put together some regular trainings to get some consistent training amongst the battalion chiefs and acting battalion chiefs and even down to the company officer level. This is our fourth event that we've had training battalion chiefs. Doc Zeeb came to me about 6-8 months ago, and with a concept of a need for grief training in dealing with, in particular, out-of-hospital deaths that we may deal with, but also just resuscitation efforts in general and stressful situations that we encounter in the field. So everybody has had an opportunity. Everyone has a book, right? The Scenes of Compassion book, and everybody's read it. Read it completely, correct? That was my prop for the day. You'll get that later. Okay, so what's the need for this class? So I had Doc Zeeb pull some statistics on MEC EMS, and this excludes the new 5 agencies that came on board with MEC EMS last year. But for 2016, we had 156 resuscitation efforts in the field. 2/3 of those, or 52, were unwitnessed, and 4 were witnessed by us, so they arrested in the back of the medic unit or in our presence. There were 12 field terminations, and 14 survived to hospital discharge. So we really want to key in on the opportunity for us to impact the families of these patients. This number does not include DOAs that we didn't work, and that number is about equal to the amount of people that we resuscitated. So who's I guess responsible, or who's had a hand in putting this together? So we had first of all, the MEC chiefs decided to sponsor this event and said, hey, there's a need out there for this type of training. So we put our heads together. Doc Zeeb put together some subject matter experts when it comes to this. So first of all, thank Doc Zeeb. Ann from Lifeline of Ohio. Raise your hand in the back. Great. Pastor Kellogg. Gunnar from Ohio Health. Megan, who's not here, but Lisa Paul is representing her. Megan was an integral part of this whole project, and she was 10 months pregnant, it seemed like, when we started, and she finally had her child. So, and again, and we'd like to thank Kevin for coming. Yay! So, without further ado, I'm going to turn it over to Doc Zeeb to get the party started here. Thank you.
So I think I have 15 minutes if somebody could wave at me when I'm at 10. So just some background. Chaplain Kellogg will be my timekeeper. Just as background, you know, if you look at our protocol and our clinical standards, we have focused quite a bit recently on termination in the field. So you know, the focus is to identify those patients who are not suitable for ongoing resuscitation and to terminate in the field rather than transport emergently to the hospital where they're going to terminate. Over the past years, we've had conversations about what resources do we have as providers in the field to help the family with termination. And we really have come up pretty empty. So we talked at one point about is there any faith-based organization out there that may represent all of the faiths but would be available to come and help us with family members? There really isn't. Some of our departments have a chaplain who will help if available. But a lot of what we've looked at really wasn't available. If you look at what we do as part of our clinical standard, the battalion chiefs or the officer on scene is responsible for interfacing with the family. But we want the medic crew to deal with the patient. We want somebody to deal with the family. And as part of that interaction with the family, we would like that officer to keep the family appraised of what's going on and to prepare the family if there's that eventual outcome that we're going to need to terminate in the field. We also have an interest in terms of providing resources to our providers so that if you terminate in the field, we can do a little bit more than say, sorry, your loved one has died, and then leave them with a law enforcement officer who may or may not be really capable of dealing with the family. Or they just don't have the resources either. So one of our goals is to identify resources that would be available for you as providers in the field to help the family. Now, we're not talking about spending 2 hours with the family like our chaplains may do at the hospital. It's more that 5, 10, whatever minute is necessary interaction, and leave the patient with resources so they have somewhere to start. Also along the way, Chiefs Rupp and Chief Ken Taylor identified Tim Dietz as a speaker who has a special focus on grief and termination in the field and how we interact with the family. They identified the text, which we've given out as kind of a reading assignment, and hopefully you've read it. So look at that. Please read it. It's got a lot of helpful hints, and a lot of what we're going to talk about today is based in part on his book. As we developed this, we realized that we all, have patients who have different preferences in terms of their religion. They have different preferences regarding their healthcare providers. So we brought in Mount Carmel Health and Ohio Health and Luke to start talking about what resources they might have available that we could use to share with our patients. So we've kind of taken a non-denominational approach to this from the perspective of religion and affiliation with healthcare providers. So thanks to those folks from those organizations, because they do this all the time, and as one of the folks from Mount Carmel said, we have a hospice organization, and what you're looking for, we have to have in order to be certified as a hospice. So a lot of that falls into this, and that's why we have resources here. As one of the materials that you hopefully picked up was a course evaluation. I hate these things. I mean, when I go to a course, I click the yes or no or 0 to 5, but ask me for the written comments. I generally don't. Well, I need your written comments because we really want to make this better. We think it truly represents material that all of us should have as a resource. So please, good comments, bad comments, let me know what you think. Eric Taft's in the back. He's recording this, and we hope to edit this and post on Workplace, so that as company officers, if you want to sit down with your crew and take snippets of what we've talked about and have them sit through it, we'll do that. We'll set it up so in Vizia, just like we do with Mech Minute, so that you can answer questions along the way and get some credits out of it. So that'll hopefully be posted. Probably take us a couple weeks to get it done, but that'll also be available for training with your crews. And you can pick and choose. It'll probably be at least 4 different segments. You pick whichever one you think is best. So you can leave mine out. You can use Gunners and Liza's and so on. So just thanks to those who are involved. We're going to talk a little bit about what is the medical perspective, and let's start with a scenario. So you're on duty and your crew's called out on a 78-year-old female in cardiac arrest. The arrest is witnessed by a spouse who attempts compression-only CPR. Dispatcher was on it that day. CPR was continued by the first in-engine company. ALS and battalion chief arrived shortly after the engine, and resuscitation is continued for 25 minutes to no avail. The crew terminates resuscitation. What are we going to do next? So that's what we're going to spend the next hour and a half talking about. Why are we holding this class? Well, our clinical standard focuses on or allows termination in the field. I can guarantee you, if you want to know how I think, read the Mech Minutes, because that tells you where I'm going to be in 6 months. But one of our focuses has been and will continue to be stopping resuscitation in the field for those patients who are not responding. You train more than we train at the hospital in terms of cardiac resuscitation. You have the same equipment, if not better equipment than we have in the hospital, at least newer equipment than we might have in the hospital. So the likelihood that you are able to, or that we in the hospital are going to be able to get somebody back that you don't get back is pretty low. If you look at the data out there, if you're an ALS a systolic or PEA arrest, the likelihood of survival after 25 minutes of resuscitative efforts is less than 1%. If you're looking at VFib arrest, it's at 43 to 45 minutes. Your likelihood of survival is less than 1%. So if you have a PEA arrest, asystolic arrest, and you've already worked them for 20 to 25 minutes and nothing has changed, the likelihood that I'm going to get it back at the hospital is less than 1%. Cardiac arrest in the field are usually unanticipated by the patient and family. Therefore, the family and the friends are not prepared for the patient's death. So how many of your patients, outside of hospice patients, is the family prepared to deal with the patient's death? There are few resources immediately available on scene to provide emotional or spiritual assistance to the family. I think you know that better than I do. Family and friends don't know what to do or expect over the following days. I have good resources at the hospital. Every time I have an unexpected death, one of the first things I hear from the loved ones is, I don't know what I'm going to do. I'm sure you hear that too. Our goal is to at least give them some guidance. But ultimately, and Tim Dietz makes this point, how you interface with the family, how I interface with the family, it has a lot to do with determining how that family or how that loved one recovers after the death of the patient. So if we're cold, callous, and don't show much empathy, if we say the wrong things, that's going to haunt the patient, or I'm sorry, the family members, the loved ones, for a much longer period of time than if we have an appropriate interaction with the patient, I'm sorry, I keep saying the patient, with the family and the loved ones. Anybody disagree with that? So this is really why we're here. Just a couple of things that I've heard over the years, just some points of clarification. Durable healthcare power of attorney. This is a legal document. It's available online. The state has a boilerplate form. You can fill in the blanks. And it names an individual that's empowered to make healthcare decisions on behalf of the patient, the person who signs the form. The identified individual can make healthcare decisions consistent with the wishes of the patient, but the designated power of attorney cannot overrule a living will. So a living will is a legal document that supersedes anything else. And it only covers healthcare issues. So in terms of healthcare durable power of attorney, it can only have to do with issues related to healthcare. It doesn't have anything to do with who can handle the bank account and so on. So that's a different document. There's a living will, which identifies the patient's directions regarding use or non-use of artificial life support, should the patient not be able to make decisions on their own. It's only effective if the patient can't communicate their wishes. So if the patient is comatose, if the patient is demented, and so on, then the living will is in effect. The living will by itself cannot really allow you as a crew to make determination of withholding resuscitation. Now, you can have a designated power of attorney on scene who says, on power of attorney, they do not want to be resuscitated. They can't speak on behalf of the patient, and you don't resuscitate the patient.
They need to provide that to us.
Yes, you need to see it. And then the hierarchy of patients' agents. So suppose you get on scene, there is no living will, there is no other material available. Can anybody speak on behalf of the patient? Well, yeah, there is something you can fall back on. So the patient's spouse is the first in line to speak on behalf of the patient. The next in line would, the legal guardian, which is usually the spouse, and then the patient's spouse, adult children, then parents, surviving parents, and then finally adult siblings. So if you're ever on scene, who can speak on behalf of the patient, this is what is recognized as the hierarchy, at least in the state of Ohio. DNRs, I think everybody knows about DNR-CCs and DNR-CC arrest. We have to have it documented. I see run reports on a regular basis where the patient's supposed to be DNR, but there's no paperwork available. Be aware that there are armbands that can be worn by patients. I haven't seen one on a patient in a while that says that the patient is a DNR-CC or DNR-CCA. And you have to be able to see it. And if the last thing is, if the DNR form is signed by the patient and appropriately countersigned by a physician, nobody can revoke that except the patient. So if the patient was at one point competent, signs a DNR form, is now no longer able to speak on their own behalf, but they signed the form, nobody can revoke it. So the power of attorney cannot revoke a DNR form signed by the patient. The patient can at any time. Role of the battalion chief, let's substitute company officer, let's substitute officer in charge based on what resources you have available. For us, logistics and scene safety always comes first. What resources do you need? call for more help if you need it. If you're first on scene, you get to do CPR and AED. I remember a patient a couple years ago where Madison's battalion, first on scene, put the AED on, defibrillated the patient. The patient was awake and talking before the medic got there. It was a great case. Doesn't happen very often. Most chiefs slow down until the medic gets there first, right? You interface with the family, and that's an important part of what we're going to talk about. So a lot has to do with the demeanor. Introduce yourself and shake hands. Okay, I'm Chief so-and-so. Identify that you are the patient's contact. I'm here to help you. I'm here to serve as the, keep you appraised of what's going on with the crew. Come up with your own lingo. What works for you? It has to seem natural. It should be natural. Is there a comfortable place for us to gather the family? So, I've been with you where, the patients on the kitchen floor, the family starts to cluster and somebody starts moving them out of the way so the crew will do what they do. So we're looking toward the battalion or the officer to help keep the family appraised, but also keep them out of the way so the crew can do what they need to do. And what's happening? So, or what happened? How did you find the patient? Did you hear him go down? Did you see him go down? Did anybody do CPR? What can you tell me about the patient? Okay. Does the patient have a DNR form? Does the patient want us to resuscitate them? That may be particularly important if you're looking at a frail 80-year-old lying on the kitchen floor versus a 40-year-old lying on the kitchen floor. Has the patient ever discussed their wishes? It's amazing how many times I get to be their first provider in the patient's contact who discusses things like code status. The patient's got chronic illness, sees 3 physicians, nobody has broached the subject of what is the patient's resuscitation status, or what do you want us to do if you stop breathing? Family interface, it's not the family's fault. And I think that sense of guilt is something we have to allay as soon as possible, because the vast majority of the time, what's happened to the patient is not the family's fault, but they start to feel guilty. 2 minutes? Oh, I better start moving faster. When we arrived, we found Mary unresponsive, or let them know what's going on. When we arrived, Mary was unresponsive, not breathing. We couldn't find a pulse. We started CPR. Did Mary ever discuss what she would want to be done if this happened to her? In layman terms, explain CPR, talk about what we're doing, the IV, the IO, intubation, whatever. Let them know the crew's working hard. And they're well trained to do this. We train on this a lot. Mary's getting the same care that she's going to get in the emergency department. My partners will shoot me, but I would advocate that she's probably getting better care. Okay? The resident's not practicing intubations on this patient. You guys practice compressions and airway adjuncts much more than we do in the emergency department. Leave and return to family. Be the yo-yo, back and forth. You're the communicator. EMS crew, what is progress? Shortfalls to response to treatment. We're working on her. She's not getting better, or she's getting better. We had a shocker, and her heart came back, or her heart didn't come back. We want to tell the family what the progress is. With the crew, you want to keep up to date, and you also want to let them know what you found out. She's got history of coronary artery disease. She's got a AICD in place, which they can probably feel. And then start introducing the idea that if Mary fails to respond, we may need to discontinue our resuscitative efforts. Family notification, make sure everybody's in the room, make sure everybody's present. Update on Mary's failure to respond. We have worked hard to revive her. We've had a couple families over the years who've complained because the crew doesn't seem to be agitated enough during the resuscitation. Well, maybe it's time to introduce, the crew as professionals. We're professionals. We practice all the time. We train all the time. Because we're not excited, it doesn't mean we're not concerned. Matter of fact, if we start getting excited, we've probably lost control. Further treatment is futile, and we need to stop. Would you like to be with Mary when we stop? That last contact with the loved one is important to the family members. So, you may not be able to get all 20 in the room, but maybe 1 or 2 representatives. Mary is dead or died. We use words dead, died, passed. Where did they pass to? So we'll talk about that. No jokes or high fives. We all have our humor, and that's the only way we survive sometimes is with our humor, but others don't understand our humor because they don't do what we do. So we all have to sometimes bite our tongues, but be careful what you say. There are a couple times, and it still happens to me after 30 years, I kind of joke about something, and then I realize that I probably should have waited till I got back to the nursing station. So be aware of that. And clean up. Don't leave a mess. Bad news in small doses. Mary's got no pulse. We'll have to shock her heart. The shock didn't work. We had to put a tube in her throat. We've been doing this for 20 minutes. We need to start thinking about stopping. She's not responding. We have tried everything without success. We're going to stop now. Would you like to be here or be with her when you do? Mary has died, or Mary is dead. Would you like some time with her? We can afford to give the family a couple of minutes with the patient, in most of the cases, unless it's a crime scene. Do they want a couple of minutes? Do they want to touch? Tips: be truthful, give the dose or the message in small doses. Allow others to spend time with their loved one if you can. Show that you care. Allow family members to grieve, and people grieve differently. We've all seen that. Different ethnicities grieve in different ways. Certain behaviors are not allowed, like throwing furniture, but people grieve in different ways. Offered continued support and cover the body. This is by Hobgood. It's in the packet. It's a resource. It's just a way of talking about grief. I can tell you I've been doing this for more than 30 years. Nobody's ever told me how I should interface well with the patient. But remarkably, over the past 30 years, I've adopted a lot of the practices which are recommended by Dietz and others, but it's by trial and error. It's not because a chaplain or anybody ever sat down with me as a physician and said, here's how you best interface with family members. Go back.
For the bottom one about organ donation, how if we stop in the field and they say, well, they're an organ donor.
We got to talk on that. So we'll have a talk on organ donation because that frequently comes up, and Ann is going to talk about that toward the end. Post-notification resources, law enforcement and coordination. Ask about clergy. Is there a clergy member, or you belong to a particular church that we might contact? You have friends that we can call. We can talk some about what happens next, and that's some of the resources we want to give you, and leave the patient with law enforcement. So we have some resources. We have some resources from Mount Carmel and from Ohio Health. We have a list of funeral homes, which we think is complete for Fairfield, Licking, and Franklin counties. And we have some resource information in terms of grief resources that are available in the 3 counties. So you'll hear more about that from the experts in a couple of minutes. Answer questions honestly. Was he or she in pain? Can the organs be donated? Again, you'll hear about that. And what am I going to do?
So I was in the hospital system for about 5 years, inside the hospital in the emergency department at East and St. Anne's, so I can give you both perspective of what we're dealing with and the hospice perspective. So what do we do? I'm a social worker as a background. How do we offer a supportive presence about death when we are encountering it on a regular basis? So the topics today we're going to be working, Gunnar and I will be talking about a grief, an introduction. How do you communicate with the bereaved? What are the common emotional responses? What do you say? There's no script, so we're just kind of going to give you some guidelines because you have to be present at that moment and be aware of your surroundings to understand what you should say to the family and what you shouldn't. Offering a supportive presence and compassion, fatigue, and self-care will be covered by Gunnar. So what is grief? Is an emotional reaction. And it shows in many, many different emotions. A lot of times you might see the family members throwing themselves to the body. A lot of times they don't want to touch the body. Nobody wants to be involved, and they expect for you to stay with them all the way until the funeral home gets there. So everybody has different expectations of what is our role, and the reality of it is that you need to be present with them and find out what do they need at that moment. Grief is going to come back at any time. and they might seem calm, and all of a sudden you turn around and you're getting ready to leave, and the whole situation becomes chaotic too. Another family member comes in, and they just realize that that loved one passed away or died. So one of the things that we want to talk about is the survivor is called bereaved, and then the victim is called the disease. Grief can manifest in many emotions. This is shock, numbness, denial, disbelief, anger, anxiety, sadness, and guilt. One of the things that I remember when my mom died, my brother offered CPR to my mom for 55 minutes before the EMS got there. That was in Puerto Rico, not here. So we have not had that experience here. But I remember when I landed in Puerto Rico, the first thing that he said was like, okay, so grief, there's the denial, there's the bargaining, there's the depression, and there is the acceptance. I think I am in bargaining today. So I'm moving along. Tomorrow, I'm going to be in a different stage, because he was very mechanical. He needed to go from step 1 to step 2 to step 3, and then I'm done with grief and I can keep living my life. So keep in mind that it is not a cycle, it is a roller coaster, and there's possibilities that you might not experience bargaining until you are way through your grief process, and then all of a sudden the denial might come again. So just because you see somebody going through that denial process doesn't mean they're going to be stuck there forever. They're going to move to another place on their grief process, and it might go back and forth until they reach that point that is acceptance. Okay, they accepted that their loved one is dead. However, the anniversary is coming back again a year later, so now they're going to move through that process all over again. So it is an ongoing process. There's no start or end point. They might be in the supermarket. They show up to the supermarket and they see some fruits that is a favorite fruit of the loved one, and then all of a sudden they no longer can cope and they start crying and they have to leave the supermarket and leave all the grocery stores because they're going to have a panic attack and leave. That is okay. That is part of the process. It can happen the first week, it can happen 6 months, it can happen a year, and it can happen during the anniversaries and holidays. So be aware of that. And make sure that you don't have an expectation that every single family member in that system is going to be at the same stage. You're going to have a family member, the husband is going to be super upset, then there's the daughter that is asking what can we do to bring mom back, and then you have the other person that is totally separated from the family situation, and they realize, yep, mom was very sick, I knew that it's time for mom to pass away, and it is okay. So everybody's going to be at a different place, and we're like, this is pretty chaotic. How can we get everybody to the same place? There's no way that you can get them to the same place. The only thing is for you to mold yourself and think, okay, this is what this person needs. I'm going to stand with the person that is in denial, and I'm going to be present with them. I'm going to let them talk and go through the process, and then you go to the next family member and you engage in those type of conversations with them without telling them what they need to do. These reactions are often thought as stages, but it's important to remember that do not occur in any sequence, and they manifest in mixed states, and reactions to loss is completely individualized. You have to realize that when somebody dies, they had a specific relationship with that dead person. So they're looking at that situation through their own eyes. They're not looking at it through your eyes, and the other family member is not looking at it through the other person's eyes. So everybody's going to react differently because of the relationship that they have with that specific person. They might have had a healthy relationship. They might have had a horrible relationship. So their reactions to grief during the same room are going to be completely different. So, for example, if a child falls and has an accident, parents attempt to revive the child, call 911, and the attempts fail. That family coping situation is going to be completely different with an 84-year-old woman that dies after battling Alzheimer's, which can be manifested in agitation, combativeness, and other behaviors that were disturbing to the husband of 50 years. So the situation with the family and how that family is going to cope is going to be completely different than the 84-year-old. So you have to wear different hats under different circumstances. So the other component, the religious and spiritual beliefs, a lot of times when we're working with Jewish families, they want to light a candle and they want to open the window to let the spirit go. So there's different beliefs, and you're like, why are they lighting a candle? Why are they covering the mirrors? Why are they opening the window? So there's different reasons. Immediately when somebody dies in the house, a lot of families will cover the mirrors so the soul will not be looking at itself and staying in the room. So they will cover the mirror so the soul, and they open the window so the soul can go. They might turn on a candle, light on a candle and put it by the window so the soul can leave out the window. So there's different things that you might find that families might do that they're completely different than you would do if somebody dies. So that is okay. We just respect it and let them do those things. You need to find out the gender of the bereaved, age, all those things, relationship, just what I talked about, previous loss history, and pre-existing mental illness. One of the things that we do in hospice is every time we admit one family member, we do a bereavement risk score for every single caregiver that is going to be there and every family member. And depending on these different things is going to trigger a score and what type of services we're going to have to offer to them while they're in hospice, their loved one is in hospice, and then afterwards for 13 months, what are we going to do? Because based on these different things, they might score different levels. They might be a high for suicide. They might be a higher risk for depression. So these are the things that we look into when we are working with them. So what do? We will do short factual sentences, just like Dr. Siep said. Do not use the words dead, died, and death. Did you hear me saying passed away? We're not supposed to say that when we are in the home. It's very comfortable for me to say to you, oh, this person passed away. The reality of it is when you're actually talking to that bereaved, you don't want to use that terminology, because if there's children present, they're going to say, what does that mean? Or they left us and they went to heaven. What does that mean? They gone home. Okay, well, let's go and get them. So when there's children around or adults that have some mental disabilities, we want to make sure that we are very factual. They're lost. Okay, can we go and find them? If there's a child, 4-year-old says, okay, grandpa died or mom died, well, we lost them. Okay, well, let's go and find them. So they're going to be very concrete. So you have to realize that when you tell them the sense of finality, that they're dead, they die, that is a sense of finality. They're not coming back, but we're here to support you during this process. We can't bring them back, but we're here present with you. Okay, now we're going to pass the baton to Gunnar.
I am Gunnar. Let's see, I've been with Ohio Health for several years as a chaplain. I got my start in this little place you may have seen somewhere along the way known as Grant Medical Center, working with the trauma team and lots of on-call in the emergency department, lots of families, the ICU at Grant, and then also at Riverside. So I've worked with a lot of families along the way around death, dying, all kinds of that end-of-life issues, leading up to both surprised and planned for, so to speak. And I now work with Ohio Health in terms of our freestanding emergency departments and manage the chaplains that respond to those. So, good morning. Common responses after emotional loss. We're going to look at those. So, we're talking about crisis. So what we're talking about is, everybody's kind of in balance, if you will, right? Today's a good day. I've got some thinking stuff going on. My feelings are kind of in check, and I'm pretty well in balance. I may be having a bad day, but I'm still pretty well in balance. A crisis comes, it's unexpected, it's sudden, it's very short duration, poof, somebody has a cardiac arrest, that's a crisis. It's in our usual coping methods, right? So I'm a little anxious, I'm going to slow myself down talking, try to breathe a little bit. Okay, that's my usual coping method. Crisis hits, that kind of goes out the window, right? So everything, all bets are off, so to speak, when a crisis hits. Everything is out of balance, is what we're talking about. There's high anxiety, emotional shock, and then, in crisis, there is, no, I'm not having a crisis. There's denial there. There's anger, remorse, grief, and then eventually we come to this reconciliation. I've made it through this crisis. So it's similar to actual grief, the grief process, the stages of grief, but there's also these stages that go through with crisis as well. Dietz talks about this really well in his book, and some of this is out of that. So those early stages, right? You respond to the scene. These are the stages that you're most likely going to encounter people going through. That anxiety and shock. What's going on? What's happening? Why is this happening? This wasn't expected. Denial. No, they're not dying. Get them back. Get them back. They're going to be okay. And you may know when you walk in the door, this ain't going to go well. But they're like, no, you're here. Oh, thank goodness you're here. You're going to save them. Right? We see that in the hospital too, in the emergency room. Oh, okay. And then they might be angry. Well, why didn't you do everything? Why didn't you do more? Well, we did everything we could, right? We pulled out all the tools out of the toolbox and we used them all. We used all the drugs, et cetera, et cetera. So they might be a little in denial. They might have some anger. Those are those early responses to crisis. Similar to grief, but responses to crisis. Anxiety, what does it look like? They might be, as you're working, they might be sitting there, what's going on, or fiddling with stuff, pacing, or just watching intently. What will we do? There's a lot of anxiety going on while the situation is unfolding. Denial, everything's going to be okay. You're here. You're going to make everything okay. I'm sorry, Mary is dead. No, not dead. I mean, I've been in the emergency room. I've had wake up, right? So I've had people, a wife, come right up to the head of the patient after the doc has pronounced the patient dead. Wake up, wake up, wake up. And what do? I just let her do that. She has to work through that denial phase, right? Wake up. There's a denial there. Refusal to hear updates about the no, I don't want to hear it. Just keep working. So you're in this kind of tension, right? Doc saying, well, we want to keep updating families. And you might have somebody denying, no, I don't want an update. Just keep working. So you got to kind of balance and work through that because you do still want to provide those updates. Walking away, no, I can't handle this right now. Well, okay, can you give me somebody in the family who can, because we need to update you, we need to keep you informed, etc. So that's kind of what denial might look like. Anger at the victim, right? I told you to stop eating all that junk food. Yelling, shouting at, why didn't you listen to me? Why didn't you listen to me? I told you what to do. I told you you were sick. Why didn't you go to the doctor? At you, do something, do more. Why are you stopping? Right? So there could be some anger there. And it's in this time where bereaved family members are vulnerable. Everything's going on. So what we do and what we say in that moment is what's critical, because it impacts the rest of their lives. And they will remember. I've met people a year or 2 years later on down the road, and quite honestly, I didn't remember that I had met them in the hospital setting or in the emergency room setting, and they're like, thank you so much for everything you did. I'm like, you're welcome. I don't know what I did. I don't even remember who you are, to be quite honest. I'm not going to tell you I don't remember who you are, right? But they remember the compassion, the sensitivity that we display and give to them in that moment. Okay? So they will remember the care and concern that we show. You may have family members bereaved who have some remorse or regret. I should have done more. I should have forced my husband to go to the doctor. I should have taken him to the doctor. I should have, why didn't I do this? Why didn't I do that? saying it's not your fault will not help. Why do I say that? They're not ready to hear that, right? They're kind of bound up in this, it's my fault, I should have done this, I should have done that. And that's part of their grieving. So, you know, we don't want them to feel uncomfortable. That's us. That's our anxiety. I want you to feel better about this. It's not your fault. It's okay. You're going to get through this. But if they're not ready to hear, it's not really going to help. And we usually say that out of our anxiety. So just, it's a natural stage, that remorse, regret, and they will move through it. And it may feel uncomfortable for us, but we may or may not really help with anything we say in terms of moving them through that remorse or regret. So you can say, you know, just repeat again, I'm sorry. Just kind of leave it at that, I'm sorry.
So in this component, if you're working with families and you start working with them and you haven't done this type of work in a while, there's a lot of things that you're going to say that are going to be completely wrong. There was one time we just opened a hospice on the east side, and I was working with a newly chaplain, and he was standing there to the family. I was talking to the family. He comes in and he tells the family, I completely understand what you're going through. I am very sorry this is happening. So he comes in trying to be a supportive presence. And sadly, those circumstances, the family completely shut down because, no, you are not in my circumstances. You don't know what I'm going through. How dare you say that I completely understand what you are going through? So we had to do some service recovery in those circumstances to help the family trust us again. So one of the things that you want to keep in mind is whatever comes out of your mouth that you're sharing with them is going to create a trusting relationship with that person at that moment, or it's completely going to break the trust. So you have to be very aware of your feelings at that moment, how comfortable and how uncomfortable you are in those circumstances. So what makes us say the wrong thing? Well, you don't want to be creating more discomfort to the family. It's very awkward when you're in those circumstances that you don't know anybody in that house. You don't know anything, any of the dynamics in there. You're just a guest in their home trying to do the best you can to bring that person back to life, and all of a sudden you're not bringing that person back to life. The person is dead, and you're going to walk them through that process. So you don't want to create more pain than they're already going through, since you were not able to resuscitate the patient. So what do? You try to make them feel less alone. You can't do that. They're going to be in horrible circumstances. They're going to be in horrible pain. They're going to feel completely horrendous about the situation, and you cannot make it better. All we can do is be there with them in those circumstances. That's the most important part that that I teach my employees, volunteers, everybody in the hospice community is, if you don't know what to say, it is okay for you not to say it. Just be there. Just let them know that you are present, and let them know that you're going to be with them at that moment. You don't need to fix it. There's nothing to be fixed. We already tried to fix it. It's not going to get fixed. Now we're going to be here present with them. A lot of times we say things to make ourselves feel better rather than trying to help them feel better. So when I started doing this work right after grad school, I kept saying to myself in my brain, am I saying this to make myself feel better, or am I saying this because it's what the family needs to hear? 90% of the time I was saying it to make myself feel better, so I just kept my mouth shut and just stay there present with them. So keep that and practice it as you keep going into these circumstances, and then it will become more and more natural. There's different terminology of saying the wrong thing. Everybody's a different personality, and we all have different filters of how we live our lives. So there is the shielding, the minimizing, the fixing, and the resorting to platitudes. So please, as I go through the slides, think about which one you identify yourself with, so we can talk a little bit more about them. So the first one is the shielding. It's the person that is trying to protect somebody's feelings, and they take information away from the reality. They don't want to see the body. They want, let's say that the neighbor comes in because they saw the lights and the alarm and everything, and all of a sudden there's the wife by the dead husband, and the neighbor comes in and says, no, we need to take her away. She shouldn't be seeing this. And then all of a sudden this random person is coming in and taking this person away. We have to step up and let them know and say, no, it is okay. It is okay for us to tell the neighbor, this is her moment. We need to let her be with that person at that time. Using the languages that we just talked about, we have lost him, he passed, he's no longer with us. So those are the things that we might react to because that's the way that we have lived our lives. So we have to be aware that not only we're not going to react that way, the people around us are going to be reacting in this manner. And what the bereaved needs at that time? They don't need that. They need us to be supportive of them. Then there is a minimizing. That is somebody that says, I just know how you feel. Like I just told you, that chaplain was trying to make that family more comfortable, connect with them, and they just instead creating that wall. So it's important for us to be aware that when you say, I know how you just feel, that's not what you're trying to say. You're trying to say, you're not alone. I have gone to something very similar, and everything is okay, and everything is okay now for me. I know it's not okay for you right now, but I survived this, so you will survive it. That's not what they want to hear, but when you're minimizing it, that's what you're trying to tell them. So what is hurt is that, hey, by the way, this is not too bad that this person died. This person got through it, I'm gonna get through it. And how they feel is like, no, you don't know how you don't have a clue about how I feel. So keep that in the back of your mind when that is coming. It's gonna come out. The filter won't stop. The fixing is an instructional response. It's an instinct for medical personnel, EMTs, and a lot of men that will say, we'll be okay. You are strong. You have to be strong. I have seen many times in the emergency department, family members turn around to a 10-year-old and say, now you're the head of the household. And I'm like, oh, great, $10 in the therapy jar, because you know that that is going to stay with them during the entire process as they grow up. That this person told me on the worst day of my life that now I needed to be the head of the household, and I'm only 10 years old. So that is something that you don't want to do. You want to make sure that you are present with them. No, they don't need to grow up. No, they don't have to play any roles. Right now, they're the bereaved. They're at a horrible place, and they don't need to think about the future. They don't need to think about something bigger. So a lot of times I just sit when I'm working with children and they have had an unexpected death. I just sit with them and just listen to them. And just listen. They have a lot of questions. They're very black and white questions, and you answer them very black and white. They're tough because they don't have all the baggage that we have in our brains. They don't have all the experiences that we have had. So we try to make things a lot cleaner for children, but children are very black and white. They can handle it. If you provide a stable environment for that kid, they can handle that person just died. Grandma just died. Mom died. My brother just died. And they're going to ask you questions, and you're going to give them the answers, and they're going to be able to, because they don't have all the garbage that we have in our brains, they're going to be able to go back to playing or walking or going back into a room to watch TV. They're still grieving, but they don't need to be grieving for 5 hours like we do as adults. They only might grieve a little bit at a time. 10 minutes, go and do another thing, come back, and then they grieve again. And then the other one is the platitudes. Resorting to platitudes often occurs when we look at ways to fill the silence. I am a talker. So as a talker, I want to not be in an environment that is awkward, and I want to make sure that I'm making everybody feel better. So it's very important that that's not my purpose. Yes, Lisa, you're a talker, but that's not what that family needs at that time. So I have to switch myself from being a talker to be an actual supportive presence and stop talking and just listen. So that is something that is a constant self-talk that I do to myself as I'm providing support to families. A lot of times you want to say they're in a better place now, they're not suffering anymore, he had a good long life, this is God's will. My gosh, that makes me so angry. How dare you like all of a sudden say, yep, God decided they're going to take this person away from me. No, that is not what we say at that moment. That is a process, and that is for the bereaved to realize themselves, not for you to point it out to them. And God needed another angel. Well, why did they take mine? Why couldn't they find another angel down the street? So those are the things that you want to keep in mind. Do you recognize yourself with any of those that we just talked about? Have you minimized the circumstances or just come up with platitudes because it helps us in an awkward circumstances? I have done it. So you can say, yes, I did it because I have done it. We're all humans. That's why we're having this conversation, so we can be more prepared to meet the needs of our community. One of the things that I love about this slide, and I cannot take credit for any slides, is the golden rule: treat others the way you want to be treated. We have a revised golden rule: treat others the way they want to be treated. So again, when we are going into these crises, this is not about our filters. This is their situation, and we're coming as a guest into their situation. So we're going to provide the support that they need, not the support that I think I need if I'm in those circumstances. And that is not easy. That takes a lot of practice and a lot of self-awareness. Being okay with the strong emotional response and ability to listen without fixing it. And that's tough, because we're fixers. We want to fix it all and move to the next thing. And in those circumstances, you can't.
So it was all about how do you break up 40 minutes so you're not just talking for 40 minutes, right? For either one of us. So that's kind of what it was. So we got all this stuff, right? Here's all this great stuff that we can think about, theories and knowledge about grief and bereavement. But there's always that question, what can I do? Here I am in the house, what can I actually do, right? How can I help them feel better? What can I say? What can I... So here's what we do. We assure care and concern. How do you do that? Introduce yourself like, hi, I'm Gunnar, I'm the chaplain, and I'm very sorry. Right? And just let them kind of say, oh, thank you, or I'm glad you're here. But the first thing I do is just let that sink in. Hi, I'm Gunnar. Here's who I am. I'm a person with you in this time. And I'm sorry. Be present. I'm focused. I'm with them. I may hold their hand. I may not. You get a sense, kind of get a sense for, is somebody a touchy person or not a touchy person, right? Don't say I'm sorry for your loss, just I'm sorry. And sometimes I'll say, well, that was my husband. Tell me about Frank. Right? Just a couple minutes, and they'll tell you something that was really important for them. Oh, we've been together for 50 years. We met at the carnival, and he was afraid to ask me on a date, and he finally did. I know you don't have a lot of time, right? But 5 minutes, you'd be amazed what somebody will tell you, and it helps their grieving process. And they're going to say, boy, that person they helped me so much when my husband died. Right? Just because you were there, you introduced yourself, you focused on them for a couple minutes, and you asked them to tell you what was important about their loved one. Care and concern is listening, not talking. It's easy for us to get anxious and say, okay, let me tell you about this, let me tell you about that, here's what's going to happen next. But to kind of push the pause button and just listen for a couple of minutes. It's not always the easiest thing to do, especially if we're like doers. There's doers and there's beers, right? If we're doers, it's hard to say, okay, let me just listen to you for a few minutes. Listening and not talking. There is a time for doing some stuff. Is there someone that I can call for you? You're alone. Is there someone I can call? Is there something that I can do for you before I leave? Right? Reflective listening, ask questions. Why did this happen? So it's easy for us to say, well, you know, the heart stopped and this was going on and that was going on, and we could start to go into medical stuff, right? That's not what they're asking. They're asking is, why do people die? I don't know. You know? Down the road, they may want to know all the medical stuff and get the coroner's report or whatever. But right now, what they're really asking is a deep question of why did my loved one die? Not medically, but why do people have to die? Why do I have to go through this? Why do I have to experience this pain and loss and separation? Lots of questions underneath is what they're asking, okay? So I don't know. I'm sorry. This must be really hard. That kind of stuff. In an ideal circumstance, right? How can I help support you in this time? Not what can I do or what can I say. What would be helpful for you? How can I help support you in this time? How much would you like to know? Is there anything I can do? Is there any information I can provide that would be helpful? So we wanted to also give you a minute, right, and talk about real quick compassion, fatigue, and self-care. There was a song years ago, Jody Messina, my Give a Damn is Busted. And compassion fatigue is, you know what, I've gone to all these runs, I've gone through all these deaths, and, you know, I'm just kind of numb. I just really don't care that much anymore. It's kind of hard for me to get my caring up. So compassion fatigue, also known as empathy fatigue, describes unique stresses and circumstances for caregivers, people in caregiving professions like us. The stress of the workplace negatively affects cynicism. You get cynical. You feel like you're not as effective as you used to be. It's not to say that you aren't, but you feel like you're not as effective. You're not at the top of your game anymore, is what you feel like. So some find themselves questioning the meaning of life as it grows and gets a little more extreme, right? What's the purpose of life? What's my grounding in the world? Right? You can become a little more irritable, a little harder to concentrate. Maybe you don't sleep as much anymore. Studies have shown that up to 50% of helpers are vulnerable to experiencing compassion fatigue. 50% of helpers. That means half of the people, half of us in this room right now are vulnerable for compassion fatigue. Of those experienced, the strongest negative feelings have been the caregiver should have coped better. I feel overwhelmed. I feel sad. I feel exhausted. It's a matter of knowing how much of the stuff can we take before we got to let it out, right? How much can we just keep going and keep going and keep going and take on our shoulders before we let it go? And in order to get this, we need to strive for balance in the workplace. We need to strive for balance outside of the workplace in our lives, to be mindful of our physical, social, emotional, and spiritual well-being. How do we keep ourselves in balance, right? In other words, what we need to have is an awareness of what we see and hear and what we feel, both. And to monitor if one of those is getting out of whack. Okay. So one of the ways that we can help relieve some of the possibility for compassion fatigue is what we call Sabbath. And I know that sounds like a religious term, right? That's why I put that title up there. It's not just for religion anymore. Sabbath is a break from whatever's going on, okay? It could be a time, it could be a place, it could be an event. So a time could be short, long, and in between. Could be a quick meditation before you start your shift. Something that you have, that you develop, that is meaningful for you, that you can just get yourself into the zone before you start, right? Could be maybe you get a break or a lunch, you do something then. Maybe you talk with Kevin or whoever your chaplain is.
No way.
No way. Hell no, right? No. Maybe there's some sense of refreshment on the go that you can dump in real quick, right? The risk for fatigue increases if there's no separation. You go from one run to the next, right? You can't control that, but what you do in between, you can control personally. Get a quick drink of water, juice, something like that. Wash your hands. There's almost a sense of like you're washing off whatever happened before you go on to the next thing. Stretch. Have some sort of a prayer or mantra that you can just silently repeat to yourself in between those two things, right? You're in the squad, you're going from one run to the next. You can just take a second and say, okay, this is going to be good. This is going to be good. Something, whatever you develop for yourself. The point is not what it is. The point is that you have something that you can do that lets you let go of what you just went through and frees you up to be ready for the next thing you're going to. Does that make sense? So it gives you a chance to let it go. Let go of the weight. Maybe there's a Sabbath space, someplace like the Violet, they have a weight room, right? I don't know about everybody else. But maybe there's a retreat area, someplace you can go in the station. Personalize your workspace. If you look around my desk, right, I've got my kids, I've got pictures of, I'm a huge hockey fan, so I've got hockey pictures. I've got a picture of Myrtle Beach. I didn't buy that picture. It's one that I took when I was on vacation. So every time I look at that vacation, I remember where I was standing, the smell of the ocean, the breeze coming off of the ocean in my face, right? It's my picture. I remember that. So it's a quick moment I can look at that. And I'm really not in my office. So is there some way you can personalize your workspace so just a quick glance gives you a quick break from everything that's going on, right? Sabbath event. This is what we often think of, right? Sabbath, you go to church on the Sabbath or, worship with a community of faith. But it could also be something you do at the end of the day, the work day, the end of your shift, or the end of the work week. Maybe there's a, God, thank you that this week is over prayer. And that helps you just mentally let it go and put it in the past, right? Leave it behind. Maybe your first thing I do when I go home every day, right, is change my clothes. Completely change my clothes. Put on something completely different. Now, of course, that's my jeans and like a Hard Rock Cafe t-shirt and stuff, but I could, right, just take off my tie and sit down and eat my dinner, but before I eat dinner, I go up and change my clothes. So I've taken off the work day and put on my home life, visibly, physically, right? Could work out, you could watch a movie, you could play. Again, it's not what you choose, it's the fact that you're being intentional about doing something that's different that gives you a chance to let go of stuff. And then some possible meditations. These are, if you like these, use them or develop your own, something that you can carry with you, again, for those moments or end of week or whatever. Just give me a sense that what I'm doing is good work. Inspire me and empower me for it. Okay? And then there's a list of suggested reading for you in your handout as well. And then we're going to turn things over to Kevin.
Good morning, guys. The stuff that I'm going to go through is not going to be new to any of you. I'm sure you've all experienced all of these things as well. So law enforcement, you've all experienced dealing with cops on the scene. They usually get there before we do, thank goodness. So what are their concerns? What are their priorities? Scene safety, control. Is it a crime scene? Is it not? Is it a natural death? Is it a sudden death? Typically they're going to want to preserve evidence. They may call the coroner based on, some protocols by the coroner, which I'll talk about in a minute. Officers will communicate to the coroner. They'll communicate to the family doctor. They will call the funeral home if we ask them to, but we can do that too. You know, if I'm on the scene, I can do that. I've done it. So that coordination, but more, the biggest thing that, as you know, the law enforcement are going to do is scene safety and scene control. You know, and not only scene control and safety for the family, but for you as well, which you guys know. Coroner. The coroners tell me that Ohio Revised Code 313 is what they go by. I'll just read it to you. You probably know this, but a good review. So, Ohio Revised Code 313.12, notice of coroner, violent, suspicious, unusual, or sudden death. When any person dies as a result of a criminal or otherwise violent means, by casualty, suicide, or any suspicious or unusual manner, when any person, including a child under 2 years of age, dies suddenly when in apparent good health, or when any person with a developmental disabilities dies regardless of the circumstances, the physician called in attendance or any member of an ambulance service, emergency squad, or law enforcement agency who obtains knowledge therefore arising from the person's duties, and it goes on, shall immediately notify the office of the coroner and tell them all the facts. So that's the criteria by which they have to come. Unusual, sudden death, suicide, suspicious, crime, person under 2, or anyone with special needs. Now the coroner will come, as you know, the coroner will come. They want to control the evidence, they want to control the scene, control the body until they determine that they're going to release the body. They're either going to take it or release it to the funeral home, right? Notifications. So notifications, I'm sure you've all been a part of those. They can, I don't know if we ever talk about a notification going good, right, going well, but we can talk about them being okay. And certainly we've all been a part of them where they go bad. We had a run a number of years ago where a drunk driver killed a person. I happened to go with the medic crew to the hospital, and the family, you know, arrived at the scene. And there was a security guard walking through where the family was and just happened to say to the family, hey, at least the drunk guy died too. And that's how they found out their son was dead. Awesome. Right? It was on the scene of a death a number of years ago, got called there. It was HVAC repairman, addicted, huffing his, whatever that stuff is, right? The fluid in his truck. Died. And the wife was like, I don't want to call his dad. Will you please call his dad? Sure. So I called the dad, said, Mr. So-and-so, I'm Chaplain Kellogg. I need to notify you that your son has died. And he's, in his words, that piece of shit huffed his stuff again, didn't he? Yes, sir. What am I going to say? Yes, sir, he did. He's dead. Arr. So every case is different. Notifications are tough, but like we've heard already, be truthful. Don't gloss over it. Be direct. I was in Ohio Health PMC the other day. Well, not the other day. It was around Christmas time. Columbus Fire brought in a lady, like mid-60s, apparent good health, just had the big one. She had been with her sister some hours prior. Sister comes to the hospital. The doctor introduced me as chaplain, and the lady just started crying. And she said, my sister's dead, isn't she? And all I had to say was, yes, ma'am. So every notification is different. Based on the needs, based on the circumstances, based on the family that's present, based on the situation, and, you know, is it sudden? Were they sick? What about news travels fast, right? Social media. How often are you at the scene and, what seems like thousands of people have already come? They're already there. You haven't even called the hospital yet, tell them you're coming, and the news is out there. So just be aware. You guys know that. Interactions with the funeral home. A lot of times, like was said earlier, if it's a sudden death, they don't even know. They haven't even thought about it. They haven't made any plans. They don't even know that there's a funeral home in town, or 2 or 3 or whatever it is. So be armed with some of that information. Be gentle with them. Offer to call. If they want to call, help them. They may want your help. They might want the coroner to do it. They will do it. The PD will do it. Like I said, every situation is different. Hospice. I am not an expert in hospice. We have folks here that are. But as you guys know, if there's the DNR, you should not be called. But sometimes that happens, doesn't it? You got to see it, right? You got to see the papers. So this is big in Dietz's book about giving family time with the body. Tell them what's happening. Explain to them along the way exactly what's happening. Offer to let them see the body. But explain to them what they're going to see. Don't sugarcoat it. They don't want to be surprised when they get there and, the tube's still hanging out their mouth. Or in the case of a car wreck, if they're mangled, sometimes that closure, that 2 minutes that they get with that body will mean a lifetime of health for them. Even if it's bad, even if it's ugly, even if, the dead person's almost unrecognizable, some people will want that time, and we should give it to them. If they don't want it, fine. We're not going to push. Sometimes you ask them, do you want time with the body? And they can't decide. They don't know. Like, should I? They're going to ask your opinion. Should I? It's up to you, right? How about your sister who's here? Maybe she can help you decide, when they talk about it. Or some different advocate can help make that decision. I don't think we should decide for them. We should offer. And like I said, explain exactly what they're going to see. They shouldn't be surprised. As hard as that is, the truth is better than to be surprised. Next up.
Hi, I'm Ann DeLeon. Get some water here. Oh, I got one, thanks. Whoops, boy, I'm jumping ahead of myself. Whoa, okay, all right. I'm Ann DeLeon, and I am the Hospital Relations Coordinator as well as Family Services Coordinator with Lifeline of Ohio. I've been doing this close to 10 years now. I took a little hiatus and went to the Pacific Northwest to see how they do things out there, but then I came back home. I came to my senses and I came back home. What we do is sort of like we're at the very end after you have taken care of the patient. And what I want to say first of all is thank you for what you all do. Because what you do is that you create situations when it's really, really sad for families to get some kind of relief or something to look forward to in a time of sadness. And what I mean by that is I'm going to give you a little scenario of a case that stands out in my mind. He was a 37-year-old gentleman, and when we talk about grief, you'll see all the stages that this mom went through. 37-year-old gentleman, heroin overdose. It was a night of, I'm going to kill myself. And so he overdosed. They gave him Narcan. He came to a couple hours later, he decided again, they gave him Narcan. Well, then he went into the basement and went into his bedroom, and everybody went to bed. Mom got up, found him. Well, she gave him Narcan again. This time, nothing. Call the squad, they came. he gets to the hospital, and he progresses to brain death. And so my job at this point is to approach the family and ask them if he would want to be an organ donor, organ tissue and eye donor. In this case, he was a registered donor. So I had to inform the family that this was his wish. The mom said, no effing way. Okay? Anger right there. I'm like, okay. And then she went off and she said, you know, the paramedics didn't do everything, you know. They could have given him Narcan again. And she went on and she was really, really angry. And so I listened to her and I said to her, just let's talk about your son for a little bit here. And he decided he wanted to be an organ donor. And I said, explain to me what you saw when the paramedics were there. And she said, well, they were doing this, this, and this, and this, but, you know, they could have brought him back. They could have gave him more Narcan, and I had more, and blah, blah, blah. And I said to her, I said, you kind of just said to me before that this was like his third attempt. And I said, you know, the heart can only take so much. And I said, I realize you're really angry. Bargaining. And I said to her, but let's just talk it through. So I spent some time talking it through with her. And finally she said to me, you know, this wasn't the first time that the squad came out. And I said, tell me a little bit about that. And she said, actually, this was the third time they came. And she said, I guess, you know, there's nothing they could have done. So she went through so many stages when I was with her, and that took place in about 10 minutes. Finally, she got to a point and she said, well, I guess we might as well do what he wants us to do. This is where we come in at this point, okay? So he's brain dead. To give you a little bit of background about Lifeline of Ohio. Every 10 minutes, someone is added to the waiting list. And 22 people die each day waiting for a transplant. And there are over 119,000 people waiting. And I'm a football fan, so when I think about all the people waiting, I think about the shoe. And I think about all that scarlet and gray sitting in every one of those seats. That represents to me everyone waiting for an organ, because I'm real visual. And there are two types of death. There's cardiac death, and I guess that's what, when you have asystole. I'm not clinical. I'm not even going to try to be, but if I, you know. So cardiac death, they die in the field. You pronounce them in the field. Brain death, you sustain them for us. They come to the hospital. Everything has to align. They progress to brain death. Okay? Only 1% of all those deaths that we see are able to be organ and tissue and eye donors, because the universe has to align in order for them to be brain death. A lot of people die cardiac death, not brain death. Okay? With cardiac death, they're pronounced at the scene, or they get transferred to the coroner's office after. They don't go to the hospital because they didn't die there. So they die at the scene. They go to the coroner's office, and the coroner has an agreement with us that they will call in the death so that we have the opportunity to look and see whether or not we can approach the family to see if this person can be a tissue donor at this point, because they're gone. We don't want to talk to the family unless everything is lined up, because we're going to add more grief to them if things don't line up. So when the coroner calls Lifeline of Ohio, and this is the pen, and this is our number for the referral, 1-877, be a donor, we're going to evaluate from behind the scenes. Now, with brain death, you sustain them and you bring them to the hospital for us. What we do at that point, we look and see whether or not they meet our triggers. And what I mean by that is that they have to have a GCS of 5 or less. So usually what they'll look for is they have to be intubated, for one thing. They're not responding at all. There's no cough, there's no gag, they're not responding to any kind of stimulation. That determines their GCS score. They're not on any sedation, so now they have no brainstem reflexes. Our ED department departments are wonderful because what they do is they will maintain that person, get them stable, take them to the ICU or CCU so that family can have some time with them. And then there's a whole process that goes through that. And then they do brain dead testing. And that's a whole nother process. And in order for us to do organ tissue and eye donation with brain death, that process is anywhere from 12 to 36 hours. And we have to be transparent with that family and let them know what they're getting into. And then you have to look at whether that patient is a registered donor or they're not. So you have to decide, and that's my job at that point, is I've got to decide now because I know they're a registered donor, so I have to let the family know. Whereas if they're not, I have to ask them because the registry is sort of like a will. Okay? Any questions, jump in, because I kind of talk fast, so jump in. Alrighty, tissue donation is after cardiac death, so they die in the field, they go to the coroner's office, the coroner will call us. We don't like to recover in the coroner's office, so we'll have to get an OR at one of the hospitals in order to do this. So, and we can do it post-recovery, and our coroners are very, very good to us, and they allow us to do. If it's a really suspicious case, it's kind of prolonged. So we get in there and we can do what we need to do. Now, you're out in the field and you pronounce the patient and a family brings up donation. We just ask you that you don't say very much. You just say, you know, there's someone that, there's an organization that will contact you after. Or you can say there's an agency that you can call, or you can talk to a chaplain. We ask that you don't get into all of that detail. Sometimes it gets murky. You have families who say, you know, and this is typical, I think, of, we're seeing a lot of it. When I was first hired, my job was to approach African Americans to see if the numbers would increase with organ tissue and eye donation. It didn't change. And I think what the thought was, what is if an African American approached an African American, you do it. Well, I'm from Jamaica, and that's a very different culture than it is here in the US. In Jamaica, you go to heaven with whatever you have. Nobody's going to take that. And so I come here, and it's sort of like the same thing. It's that suspicion that you're going to take my organs and do whatever you want with it. So when I did that grant, all I got was, I had this one, I can never forget this one case I had with an African American family, and the daughter said to me, well, I'm not giving you anything because my mother has been on a waiting list for a kidney for 5 years and she never got one. What am I going to say? And so I never got the opportunity to explain to her the waiting list and all of that process, and she just said no. So these are some of the things that you come up against with families. So going back now to behind the scenes, Lifeline will screen the potential donor. We have access to Epic, and so each hospital we can go in once a referral is made and look at the history, the medical history of that patient, so that we don't call that family and set them up again for more grief. So it's so important that we know what we're doing, because we will rule out. Tissue is regulated by the FDA, and it's very stringent. And if you're a HIV user, you won't be a tissue donor at all. HIV, Hep C, we're seeing a lot of hepatitis, that's a rule out. So we don't want to set that family up again for another loss. So if they're not viable for tissue donation, we don't even call them. Okay? Your role. I can't emphasize enough how much what you do for us is so wonderful, because you provide information that is vital to us in terms of whether or not that patient got this, and this, and how much you gave them. Because we have to have blood, and if that patient is hemodiluted, we can't figure out whose blood is what and how much of their blood, or is it just what you gave them. So documentation that you give us is huge, okay? your run sheets. When you leave your run sheets for us, that's what we use to determine how much medication you gave them, how much fluids were given, what fluids were given, when they were given the last sedation. Like if you gave them VEC, we want to know how much, we want to know the last time, because that's important too for doing brain death. Okay? So the ED, I'll have to go to the ED and constantly ask for the run sheets when we have a donor. And I work with Grant and Riverside, and you guys are really good at Grant and Riverside. I can usually get them because we'll need that, especially for tissue, all of that information. And I won't read it to you. You guys know what you do, and we so appreciate that, okay? But proper infusion times, that's huge to us too, because we have such a window. We really have a window of 24 hours. So if that patient dies on the scene, we have to get them in cooling, because the clock starts ticking then, and we're behind the scenes and we're looking at everything that you've given them, okay? Documenting their cardiac rhythms. We need, what's important to us too is if you can find out for us when the last time seen alive, or if it was a witnessed arrest, whatever, that is also important to us. Because again, the purpose of all of this is to give that family the opportunity for donation. And I remember I like to tell stories because I think it sort of just connects everything. I had a mom who lost her daughter. She was 16 and she had just started driving. And that mom was so happy because she got to connect with that EMS person. And that EMS person witnessed the accident and was able to hold her daughter's hand and was able to tell her everything that he said to that daughter. And we had the best run sheet on that particular case. And that mom was able to say yes to donation. Daughter was registered, but she was able to, because at 16, you still have to get parental consent. She was able to say yes. And that mom, I'll never forget, that mom said, "It is because of everything that was done in the field that I'm going to be able to go on, because I know my daughter will live on in others." And for her, that created the best way for her to move forward. So when I say to you, everything you do connects to our donors and our donor families. And it's really instrumental that you know that. For me anyway, I'm such a sap anyway, and I like to thank people because you don't always hear the good things that you do. But I'm here to tell you, it makes a difference in people's lives, and it helps them with their grieving process, okay? So, high-risk behaviors, I talked about that. Those are some things that rule them out for tissue. Now, for organs, it doesn't really rule them out as much because you have people who are hepatitis C, hepatitis B, who are waiting for organs. HIV is no longer a rule-out because you have people who have HIV. So don't rule anybody out, and don't rule yourself out for any kind of donation. Leave a copy of that run sheet. I like run sheets. Okay? Thank you. Any questions? I have pens, by the way.
All right. So